This is a short video on orbital anatomy. For lack of a better term, today we'll be exploring the various orbital holes and focus specifically on the fissures of the orbit. There are two fissures that are worth considering at this stage. The superior orbital fissure. The superior orbital fissure is a bony cleft that is found near the orbital apex and divides the lesser and greater wings of the sphenoid. It provides communication between the orbital cavity and the middle cranial fossa. The superior orbital fissure can be described in relation to the common tendinous ring, also known as the annulus of Zinn. This is a fibrous ring of connective tissue at the orbital apex that is the origin of the four recti muscles. The common tendinous ring splits the superior orbital fissure into three distinct anatomical sectors: the superior segment, which contains four key structures, the central segment, which contains four key structures, and the inferior segment, which contains one key structure. This is difficult to visualize on our atoms models, but is worth a bit of imagination or props so that you can picture the common tendinous ring as shown. There is one helpful mnemonic that can be used to help us remember the various contents that belong to the superior segment of the superior orbital fissure. This is referred to as the segment that is outside the common tendinous ring. The mnemonic is liver function tests, or LFTs, which stands for the following structures: lacrimal nerve, the branch of V1 of trigeminal; frontal nerve, the branch of V1 of trigeminal; trochlear nerve, cranial nerve 4, and the superior ophthalmic vein. For the central segment, also known as the segment within the common tendinous ring, it largely hosts the rest of the cranial nerves that innervate the extraocular muscles and can be remembered as ONAS. Oculomotor nerve, cranial nerve 3, nasociliary nerve, branch of V1 of trigeminal, abducens nerve, cranial nerve 6, and sympathetic fibers, which are postganglionic fibers that pass through the ciliary ganglion. The inferior segment of the superior orbital fissure only contains one structure, and this is a branch of the inferior ophthalmic vein. In brief, we shall discuss the 9 structures that arise from the superior orbital fissure and their functions. The lacrimal nerve is the smallest branch of V1, the ophthalmic nerve of the trigeminal. The lacrimal nerve provides sensory innervation to the lacrimal gland, lateral upper eyelid, the superior fornix, and the lateral forehead. It receives parasympathetic fibers from the zygomatic nerve to supply the lacrimal gland. The frontal nerve is the largest branch of V1, and it is pure sensory, providing sensory innervation to the forehead, frontal sinuses, and the upper eyelid. The trochlear nerve is cranial nerve 4, and it provides pure motor to the superior oblique on the contralateral side after decussation around the brainstem. The superior ophthalmic vein drains most of the globe, upper eyelids, and extraocular muscles as well as the lacrimal gland, and it directly communicates with the cavernous sinus. The oculomotor nerve is cranial nerve 3, and it provides pure motor to the majority of the extraocular muscles tasked with eye movements. This excludes the superior oblique and lateral rectus. The nasociliary nerve is the intermediate branch of V1, and it is pure sensory nerve that provides and gives off branches in the form of the long ciliary nerve, short ciliary nerve, and communicating branches. It largely supplies sensation to the cornea, conjunctiva, and the mucosa of the nasal cavity. The abducens nerve is cranial nerve 6 and provides pure motor to the lateral rectus muscle. And finally, there are sympathetic fibers that arise from the superior orbital fissure that are tasked with dilating the pupil, lens accommodation, and elevator function of the superior tarsal muscle, aka Muller's muscle. The inferior orbital fissure. The inferior orbital fissure is a bony cleft that is formed by the greater wing of the sphenoid and the maxillary bone. It starts posteriorly along the boundary of the orbital floor and lateral wall of the orbit. On our atoms model, it is significantly exaggerated and a large opening, as seen in the model, but in reality the hole is much smaller and thinner. The contents of the inferior orbital fissure can be remembered as the mnemonic inferior orbit gets infraorbital nerves and veins. This includes the following structures: IO, the inferior ophthalmic vein; G, ganglionic branches from the pterygopalatine ganglion, providing parasympathetic fibers; ION, infraorbital nerve, branch of V2 of trigeminal and its associated neurovascular bundle, i.e. the infraorbital artery and vein; and Z for zygomatic nerve, a branch of V2 of trigeminal. In brief, we should discuss the 4 structures that arise from the inferior orbital fissure and their function. The inferior ophthalmic vein has 2 branches: a superior branch that drains through the inferior segment of the superior orbital fissure, and an inferior branch that drains through the inferior orbital fissure. The inferior ophthalmic vein drains the inferior orbit and is much smaller than its counterpart, the superior ophthalmic vein. The inferior ophthalmic vein drains into the cavernous sinus and the pterygoid venous complex. The pterygopalatine ganglion is one of 4 parasympathetic ganglia of the head and neck. It receives parasympathetic fibers from the facial nerve. Postganglionic fibers from this ganglion travel through the inferior orbital fissure to supply the lacrimal gland via the zygomatic nerve and parts of the nasal cavity. Remember, the zygomatic nerve was discussed in a previous video on foramina in our atoms series. To recap, the zygomatic nerve is a branch of V2 of trigeminal, and it enters the orbit through the inferior orbital fissure. It runs anteriorly along the lateral wall before giving off parasympathetic fibers to the lacrimal gland. Afterwards, it dives into the zygomatic bone and gives off 2 further branches that leave the orbit, and this is the zygomaticotemporal, which travels towards the temporal region of the head, and the zygomaticofacial nerve, which travels towards the cheek. Finally, the infraorbital nerve and its associated neurovascular bundle were also discussed in the previous atoms video on foramina. To recap, the infraorbital neurovascular bundle travels in the infraorbital canal and leaves the orbit via the infraorbital foramen. The infraorbital neurovascular bundle supplies parts of the cheek, lateral nose, upper lip, and the mucosa of the nose, mouth in the maxillary distribution of the trigeminal nerve. Clinical application. From a clinical perspective, it is important to be aware of the various structures that arise from the foramina and fissures of the orbit, as they can be compromised when there are orbital lesions that compress the surrounding neurovascular bundles within the orbit. Orbital apex syndrome affects the most posterior part of the orbit, the apex, as shown here, and it will commonly compromise the contents of the optic foramen and the superior orbital fissure. Through this process, it will knock off the optic nerve, manifesting in visual loss, and contents of the superior orbital fissure. Ultimately, this leads to a collection of hypothetical presentations depending on the structures affected, but mainly it presents with multiple cranial neuropathies, including ophthalmoplegia, absence of corneal sensation, significant reduced ocular motility, and most importantly, reduced visual acuity due to optic nerve involvement. The causes of orbital apex syndrome are wide and range from inflammatory, such as thyroid orbitopathy, infectious, such as orbital cellulitis or invasive fungal sinusitis, neoplastic, such as hematological and neural tumors, and traumatic, such as displaced bony fragments following high-impact trauma. The main symptom, just to repeat, that accompanies orbital apex syndrome is the loss of vision due to optic nerve involvement. This is the key differentiating characteristic from other syndromes that might impact the orbit. Other signs that relate to the rising intraorbital pressures from an orbital lesion include proptosis, chemosis, and periorbital pain. Superior orbital fissure syndrome, it is the top differential to orbital apex syndrome. It is rare to find on its own, and it is mostly the stuff of case reports and case series. The main differentiating factor between orbital apex syndrome and superior orbital fissure syndrome is the vision loss due to optic nerve involvement in orbital apex syndrome. This is not present in superior orbital fissure, since the superior orbital fissure does not give way to the optic nerve. Other clinical symptoms or signs to be aware include ophthalmoplegia due to oculomotor, trochlear, and abducens nerve involvement, ptosis due to loss of motor supply to the levator palpebrae superioris, and sympathetic loss to Muller's muscle, a fixed dilated pupil due to parasympathetic loss to the oculomotor nerve, and lacrimal hyposecretion due to loss of the lacrimal nerve. Once again, the collection of these signs is hypothetical and more in keeping with the theoretical knowledge of the structures that pass through the superior orbital fissure. Further resources. Further resources on superior orbital fissure and inferior orbital fissure can be found on Wiki by the American Academy of Ophthalmology, and Radiopaedia has some excellent anatomy articles. This will be referenced in the description below. Thank you for listening, and stay tuned for more orbital anatomy videos.